Good afternoon and welcome to Webinar Wednesday. We're excited to have over 330 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. Let's get started by giving one lucky attendee a Webinar Wednesday lunch bag for answering this trivia question. Today's sponsor, PartSource, is headquartered in Ohio. Which city was home to the first ambulance service, which dates back to 1865? Answer now using the questions feature on your dashboard. While you're answering, I want to invite everyone to join us for our annual imaging conference and expo, which will be held February the 17th to 19th, 2019 at the Wyndham Grand Resort Hotel, Clearwater, Florida. The ICE conference will bring imaging service professionals from across the nation to Clearwater for 3 days of learning, networking, and the latest advances in imaging. Registration is now open. Details can be found at attendice.com. Okay, and let's see who the winner of our Webinar Wednesday lunch bag is. And it is Virginia Schill Mason. Congratulations, Virginia. The correct answer is Cincinnati. Webinar Wednesday would like to thank our sponsor, PartSource. PartSource combines a suite of software-enabled services with industry best practices and empowers customers to drive variance and costs out of the hospital supply chain. By automating the highly complex workflow associated with procurement, PartSource delivers the industry's only online, fully integrated medical replacement products marketplace. Visit partsource.com for more information. Our presenter today is Glenn Schneider, Director of Clinical Engineering at Cincinnati Children's Hospital Medical Center in Ohio. Glenn, you may begin whenever you're ready.
Thank you. Good afternoon. I'm Glenn Schneider. I'm the Director of Clinical Engineering and I wanted to talk to you about a couple of issues that we are finding across our profession, as well as many professions in these days, but using lean practices to gain efficiencies, and using a intern program to staff future staffing for labor shortages. So a little bit about Cincinnati Children's. Our mission is to provide the best care for kids and to transfer delivery of care through integrated, globally recognized research, education, innovation. I'll give you a little bit of information about our facilities in the presentation. And our vision is to be the leader in improving child health. Children's hospitals are very willing to share information with each other because it's about taking care of the patients across the country. Cincinnati Children's Hospital was established in 1883. We are the Department of Pediatrics for University of Cincinnati College of Medicine. They perform their residency for pediatrics at our organization. This year we moved up to number 2 nationally in U.S. News and World Report, and we ended up in the top 5 in 9 specialties of the U.S. News and World Report categories. We're also number 2 in pediatric research grants from the National Institute of Health. We have 678 registered beds. Our main hospital, we have 463 beds. We have a campus on the north side of the city that has 42 registered beds and is primarily an outpatient facility. And 2016 opened a proton therapy modality there in collaboration with the University of Cincinnati. We have a College Hill facility, which is our psychiatric facility, and we have 102 inpatient beds and 30 actual residential psychiatry beds. Our admissions are over 33,000. We have almost $180,000 ED and urgent care visits. over 1 million outpatient visits per year. This is the 2017 statistics. We did 35,000 surgical procedures, over 1.3 million patient encounters. We are the second largest employer in the city of Cincinnati at 15,750. Our operating revenues are 2.3 billion and net hospital patient revenues 1.6 billion. In 2017, we provided $225.1 million in free or discounted services and 5.5 million in services to community and nonprofit health organizations in and around the city of Cincinnati. So we have patients from all over the world that come to seek our services. We've in the last year, we've had patients from every state, 58 countries and 589 international patients. They primarily come for our Cancer and Blood Disease Institute, and that's been the top draw for the last couple years of international patients. We have a collaboration with the University of Kentucky, and we provide joint advanced pediatric heart care, mainly for the patients in Kentucky. It's strictly a pediatric heart collaboration. Recently, we broke ground. We are just started an expansion at the end of last year. It's a 600,000 square foot clinical care expansion, ICU expansion, and that's to better serve, obviously, our most critical patients. So this is the breakdown of our department. As you can see, we have not adopted the HTM name yet. We do use it, but we have not made that conversion from a internally. So all of my slides are going to be referencing clinical engineering as our department. So we have 37 full-time employees. Certification is a requirement for advancement in our department. I am the lone CRES certificate holder. We have 13 CBETs, 1 CLES, and 1 employee that has both the CLES and the CBET. We have a director, a clinical engineer, an equipment coordinator, and recently acquired a data analyst to help us with our data, which is another trending change in our profession, is where everybody's relying on a lot of data. So we wanted to support that. We do a lot of good things, and we wanted to be able to capture that and provide that to our leadership. We have 3 lead technicians, 1 that is over the general HTM area. We have 1 over imaging, and we have 1 over our lab and research combined group. We currently have 9 specialists that are broken up into several areas: anesthesia, OR, we have imaging, respiratory, lab research, and we have 7 senior technicians, 14 CE technicians, and we currently have 11 students. So the breakdown of our 4 technician groups is the CE technician, senior technician, CE specialist, and CE lead. We do not have all 11 students at one time, and I'll show you here as we go how they're broken down. They're by semester. So at any time, we have 8 CE technician co-op students and 2 bioengineering students from the Louisville Speed School, which I will show you their information later, and then 1 computer science student. We cover 66 buildings total, 8.2 million square feet. And our active clinical devices, we have just under 40,000. and active lab research devices, we have almost 24,000. So age is a big factor, like as we're talking about succession planning. And so to look at our department, our average tenure of our employees, our full-time employees, is 12 years. And our average range for a technician, our technicians, is 42 years. Of all the technicians, our average age is 42 years. We've recently had we had a couple of folks retire, and we use the CoOp program as a feeder to support and bring in new talent. The average age of our specialists is 52.5 years. Our senior technicians is 45 years, and CE technicians is just over 33 years of age. The management, which would be the clinical engineer, the director, the leads, our average age is 56 years, and we have our administrative average age is 29 years. So as you can see, our very talented folks and experienced folks, we've got a lot of pending turnover coming. So we have a school relationship with Cincinnati State for our technicians. They are a couple of miles down the road from where we're located. I know that everyone doesn't have access to students, but one of the things that we tell the students when they come to our organization is you have to be willing to move, you have to be willing to relocate, because there's plenty of work out there. We can't hire everybody that comes through. The local hospitals can't hire enough people as they come through. So a lot of the turnover, or I should say the folks that have went on to other organizations, we've had some of our students that have worked for a couple of years and then they found positions elsewhere. They have almost all of them have taken positions that are either traveling or located in another city. So Cincinnati State requires 1 semester of CoOp, and they recommend 2, but they require 1. And we tell the students when they come in that we prefer 2, and that's our goal, is to have at least 2. We feel that 2 is the minimum requirement we need to really be able to educate everybody and get them to where they need to be when they leave here. Our goal is to have them ready to take on a full-time role when they leave here with little other than factory training, with little problems. Halfway through our semester, we begin interviewing for the next semester for those that are not returning. The coordinator and our CE leads typically perform that. We do tell the students, and one of the requirements is for their performance, we don't invite every student back. We have had students in the past that, due to their performance, we have told them that they would not be returning. So it's not a guarantee that when you get a co-op position that you're back for all of the 2 and up to 3 semesters they can do, but we don't guarantee that when they are first hired. Our starting pay is $12 an hour, and that's a competitive. We keep competitive with the other programs that or other organizations around Cincinnati that have co-op programs. So our bioengineering and our computer science students. They come from the JV School of Engineering at the University of Louisville, like I mentioned. Their program requires a minimum of 3 co-op semesters. They don't have to all be in the same place, but they require them to complete 3 co-op semesters. So we require 3. We do that mainly for stability, that we're not constantly bringing new students or having to interview and bring in and train new students every semester. And it has worked out pretty well. Same thing, we interview halfway through the semester, and the coordinator and the clinical engineer perform those interviews. And again, they're also they return, and it's based on performance. We are some of the things. Well, in a bioengineer, their starting pay is $14 an hour. So our goals with the students is to perform, or to teach them. We help them with resume writing. We provide them the tools they need to take to an employer when they leave a list of all the equipment that they worked on. We have forms that they use, that they fill out, and they work with our technicians, and our technicians sign off on it that they have completed the particular activity, whether it's a preventive maintenance or a repair or whatever that happens to be. We do not require it. We just provide them the tools. It's up to them to take advantage of that. We have some that take advantage completely, and some that don't. So we have a rotation. So our general shop, we have 3 students for a full semester and 1 that is there for half a semester, and then we do a rotation midway through the semester. So it's about 7 to 8 weeks into their work that we rotate. And by the second semester, when they're here for the second semester, they're fully aware of everything that's going on, and it's a very easy transition. The first time, it's a little bit of a bump, or a little bit of a learning curve, but they pretty much are right on cue after that. We do maintain the beds and stretchers, and lumped into that is, being a children's hospital, we have cribs, we have climber cribs, we have incubators, we have warmers, and a lot of all of those. So that is one area that we do maintain. We manage and maintain those devices. So we have a student and for half a semester, they rotate through that. At our Liberty Township campus, we same thing. We have a very robust home care program that we have one full-time, and we're actually trying to justify a second full-time position for that, which would be 2 full-time people and a student for full-time down there. Our research group, we put a student over there. They rotate through that. And then we try to work in. Our imaging team has been extremely generous with trying to get the students into experience the imaging modalities. And they have, I have on here that it's a 2-week per cycle, depending on workload, but it's kind of catch as catch can, depending how the workload goes. Sometimes it's more often, sometimes it's less. So has it been successful? We feel it has. So I'm going to go through some work order completion. We did a lean collaborative, which is the other part of the presentation, and the numbers on how we use it as a career path for them. So this was our calendar year statistics for planned maintenance. These are our overall statistics for our full team, our whole team. So the quarterly scheduled PMs are only the high risk and non-high risk items. And so we did, 18,000 PMs over the course of 2017, and 4,700 of those were completed by students during their work period. For repair and unscheduled, we had, again, well, this is for all clinical. We had 16,000 corrective maintenance work orders, and over 3,000 other type of repair work orders or PM or hazard recalls. And the students participated in about 3,700 of those. So since 2010, 12 of the 14 open positions we have had were filled by students that perform their co-ops at our organization. They, one of the things that we tried to set up is a career path for our full-time employees. So when we have a retirement or a person that has experience leaves, our goal is to have someone waiting in the prepared to enter into that modality or that area, and basically take on those responsibilities, and then we backfill their position. And we try to bring entry-level people in. It's not that we will not bring people with experience in, it just depends on the situation, but we try to get the group we try to have a career path for our own full-time employees, and then backfill it with those young people. So, and that has worked out very well for us. We lost my train of thought. So here is an example of one of our successes, and this is our lean project that I wanted to talk about. We did this in 2017, and it was a collaboration between multiple groups, mostly clinical engineering, but multiple groups. So we had a team of 5. We have a collaborative that the organization has set up that does classes, and this is the requirements. You have to have a team of 5 and you have to have a project. So our team of 5 consisted of 4 of the clinical engineering representatives, and we had 1 person from our DME EVS logistics group that they are the ones that deliver and clean the devices. So here is the Anderson Center at Cincinnati Children's has this Quality Improvement Lean Collaborative, and it's an 8-week course that uses hands-on exercises to teach multiple 5-person teams and each team is assigned a coach. So this collaborative started in March of 2016 when they had the first training class. There were 4 projects. In November of 18, they will have been through 12 classes. That group has 8 projects. And in all, over those 2 years, there's been 75 projects completed. And you have 4 sessions, so you attend 4 sessions. And in the 4th and final session, or I'm sorry, you have 5 sessions. In the 5th session, the CEO and or COO is who you present to. So it's a very, very high level, high level leadership is very interested in this program and the success of it. So what I want to do is I want to kind of help those who do not have lean, do not have access to something like this. I want to kind of go through our process. It's not something that you can't do without a trained lean person, you can definitely do it. Sometimes you look at these things and you think, wow, that's common sense. But sometimes you just need that somebody there to help you through and get through some of these things. So I just want to kind of outline the things that can help you get there, and you can apply yourself. Ours was a very physical project, and it was very easy to see the results, but don't feel like any smaller project would not be as successful, because every little bit of efficiency helps. So the first thing is to make sure that everybody's on the same page from the top down. That way, when you come up with ideas that require resources, you have a way of getting them, because if your department or your division leadership is on board, they will help you make those changes. They'll help you get to where you want to be. Sometimes it's changes that have to occur outside of your department, but you don't have the power to make those changes, but they can at least help you get to the right people to make them. Get everybody in the department involved. Just because this project might be focused on one particular group or a couple of people maybe, or one particular area of responsibility, doesn't matter. Get everybody involved. You will be surprised what kind of ideas you get from people who you would never guess that they would come up with great ideas. Anybody that comes up with an idea, you need to vet it out. You need to encourage them to give you ideas, and you need to examine every idea. Even if you know that it's probably not going to work, at least give it a little bit of attention, but report back to the person that gave you the idea so that they know that you just didn't blow them off. Because that's at least if you come back and say, hey, we looked at this, but we can't do it, then you got to let them know. They'll accept that if you tell them that you vetted it out. Clearly define your problem. It's very easy to scope creep on this, so you need to clearly define your problem and where you are and where you want to be. Find a good starting point, and don't bite off more than you can chew. Pick small things. That's one of the things that they push with the lean projects, is if you try to take on too much, then you're going to fail, and then you're going to people are going to become disinterested. They're going to think it's not going to work. If you just take little tiny pieces and success and win and celebrate those successes as you make them, you'll gain steam, and you'll pick up people who may not be on board when you start this. They'll start to see the value in it. Provide regular updates to your team and to your leadership. That's the way you're going to buy in and get buy-in from them, is to keep them posted on everything you guys are doing. Some of our team members who are not directly involved in the project provided support by helping with work that people that were involved on the team, to free them up to do that work. So it's a departmental effort. It's a team effort. So make sure you acknowledge that, and make sure you celebrate those things, and bring that to everybody's attention, and show your appreciation. So we had a 60-day strategy because that was the cycle of the class. The 4 classes were over a 60-day period. So this is what they call an A3, and this is our entire project. So that's lean. You do it on one piece of paper. It's on an A3 size sheet of paper. So I'll go through this. So the background on this is that we wanted to take on DME as a project, and we wanted to fix the problems we had. So as everybody knows, DME has become such a huge consumer of time for us, that it was necessary to get some control over it. So our department had, before we went to our current pump system, we had 2 people that were dedicated to DME work, but we made some changes to our responsibilities in the department. We wanted to make sure we had everybody was more well-rounded instead of focused. We had a very focused groups that were very focused on specific equipment, and we didn't feel that that was necessarily the right model. So we changed it so that we had more well-rounded technicians on basic equipment, so that we felt that the DME was part of that. So it was split among several people, and it really turned out to be kind of a disaster because there was no accountability for anybody for some of this equipment. And you will see as I go through this just how disastrous it was. Our inventory of our DME routinely fell below our par levels. We have a daily inventory count of pool equipment that is published, and it was consistently, we had items that were consistently falling below those par levels. We had a lack of an organized repair process, and as everybody knows, that leads to a low availability of the pool, just what we were experiencing. It gave a false indication that we didn't have enough equipment, because there was so much of it that was out of the circulation of the pool because it was in our repair process, that it looked like we didn't have enough during high demand times. And we were operating on a reactionary process, not a proactive, and we wanted to switch that. So our original goal was to do all of DME, but our coach talked us off the ledge and said, hey, you need to scale this down to just the CareFusion devices, small pieces. It's actually 4 devices, 1 manufacturer, and we do have an inventory of approximately 4,000 of these devices. So what we wanted to accomplish was a reliable intake process so that we could get some measurable results. We wanted to create an intake process of the equipment so that it was not sitting, and it would come into the repair process, and we wanted to capture that clock time right at the start. And we wanted to reduce how much time the pumps were out of circulation. And in this process, we were going to define roles and responsibilities of the team. So this is our what they call a current state. This is a process map that gives each green item is processing time, and each yellow item is lead time. So the green and the yellow are basically added. The green is included in the yellow because lead time is the entire process from start to finish, and each process, the green is for that particular piece of process of time. So part of our current state, we had basically a 41-day turnaround time based on what dates we had on our tags that we had of equipment being repaired, and our processing time was 4 hours. So we lacked organization of our intake racks of storage and how our intake racks were set up. Our triage process had items, we were cherry picking. People were cherry picking the specific items they wanted, whether it was based on need or based on what they wanted to work on. We had an unstable parts inventory. We had devices all over the shop that were waiting parts with no identification on them as to what was wrong with them, if there was anything wrong with them. They were not located very close to the benches of the people that were working on them, so a lot of time walking around finding stuff. And we had long wait times between performing various work, and we had no first-in, first-out process. So those are the problems we had, and this is where we wanted to be. So we looked at all of that, and our goals were to get our lead time down from 41 days to 4 days. and our processing time down to 2 hours. So we worked on incoming devices as they were pulled from service, that they were cleaned appropriately before they were put on our intake rack. We developed a standardized workflow for bringing the equipment in and work order generation, and I'll show you a little bit of that here shortly. Daily would go out, and we set up daily going out and pulling inventory or devices off of the intake rack in to bring into into the process. We created a triage process so that we could identify items that were tagged with a problem description, items that were tagged without a problem description, items that were not tagged at all, and items that were involved in incidents. And we wanted to assess parts needs and get that organized, and we wanted to clean up the area, the work area in general. So here was our target. Our target was to reduce the turnaround from 40 days to 4, based on these particular items I kind of mentioned. And these were our improvements. So we had no intake. We created an intake. Some of the items would sit out there for 16.5 days. We got the intake process down to 24 hours. We saved 15.5 days right there. What we had been doing was bringing things in, fixing them, then creating and closing a work order. So all of our work orders looked like they took a minute, where they were actually taking a lot longer than that. We improved that process. They would sit sometimes up to 11 days, and we reduced that down by 9 to get that turned around to 24 to 2 hours days, and that's whether they're waiting parts or in repair. And then again, we defined roles and responsibilities, and by doing that, we cut a lot of time out. So again, 40 days, our target was 4. We actually got it down to 2. So it was a huge success. So this is a 26-day timeline from when we started the process. 49% of the pumps we turned around the same day, and then 98% were completed within 2 weeks, and 75% were completed within 2 days. So 75% completion within 2 days from where we were was a huge success. So these are the things that we're looking at doing. We continue to look at how we do things and review them and improve. We are trying to identify the parts and ordering the specific materials we need so that we do not stock items that we don't use a lot of, and we stock items that we need the most of. And we're going to spread this. We're going to take it and we're going to try to spread it throughout the department. So this is what our intake rack looked like prior to the process. As you can see up on the top shelf, there's a big bottle of alcohol. There's trash that people throw on it when they walk by. It was a nightmare. And so this is what we have now. So the rack is labeled with specific items and what's to be placed on there. And on the wall, you can't see it. It's actually not in this picture, but we have a flow chart, and it's in one of the next pictures that we have posted on the wall, and that describes the intake process. So the DME folks, when they collect items from the solar utility and they clean them, they bring them down here and they put them on this rack. This was one of our workstations, or 2 of our workstations. We actually converted into doing specifically Care Fusion, and this is what they are now. So we have a FirstIn FirstOut system on the top row. We use magnets, so items are dropped off and they're put in section 3, and then as the technicians come in, they work on section 1 into section 2 and as far as they can get for the day, and then wherever they stop, we move the magnets around to identify that's where they stopped, and then the next day it gets loaded up from that point into section 3, and that provides us with a first in, first out. Again, it's our rack. So this is our new process. So we have the flow chart. We set up we have the Four Rivers TMS application. We set up a barcoding system, or we use the web interface to set up a intake process. Our technician goes out with a laptop. Typically it's a CoOp, sets up the laptop, barcode scans the asset number, does a quick search to see if there are any open work orders. If there are no open work orders, there's a second field to fill out, and we have barcoded all the most common problems, and they can just barcode scan the problem and it loads it in. They submit it, the work order is created, and the clock starts ticking. So that was our intake process, our new intake process to get to capture our turnaround time. These are our transport carts to take things to and from the DME room. They go back to the DME cleaning room once we're done with them, and to be cleaned and put back in the pool. As you can see, they're just carts. They're not marked. And as everybody knows, you leave that like that on at 3:30 when you leave, and when you come back, somebody's taken it off and put it somewhere, and they've used it. And we are a 24/7 shop, so we have 3 shifts. So these things will be gone. They'll be all over the place. We identified them. We actually bought 2 Rubbermaid carts, and we painted them green and red. The only time broken equipment is on the green is if we deliver to the DME, we pick up whatever up there to be brought back down during the day, and we bring them down. They're triaged exactly like the other ones, and they go into the repair process. So what's happened since then? It's been a year. We implemented a 5-day quarantine period to help with incident investigations. Sometimes the staff are unable to put incident investigations in for a day or 2, and we did not want to let these devices get out. If we suspected they were involved in an incident, or we were called to the floor to pick one up, they automatically go into a 5-day quarantine, and if we don't see an incident report, then we fix them and put them back out. If we do, then we have them, and we don't have to worry about hunting them down. We've had 2 syringe pump recalls in the last since we did this. We have 1,091 devices, and as you recall, CareFusion had, those of you that have these devices, had a syringe pump recall, and we were in the middle of it, and they came back and said, "Oh, sorry, that didn't work, so you need to do it again." So we had those. We had our own large volume pump internal recall where we had some fluid intrusion, and did some work with our cleaning, the DME cleaning folks, and did some re-education, but we had to investigate to find out how bad our problem was. So we had to basically opened up all of our large volume devices to inspect the inside and clean them. And then we've had multiple DME replacements and conversions over the year, new feeding pumps, we're actually in an SCD conversion. Those are all projects that takes away from our DME team, and that's why I included that in here. And so at the end of UptoDate this year, this is where we're at. We are still 38% turnaround same day, and about 57% completed in 2 days. So we're not where we were, but we're still we're hanging in there, and we're still trying to make things better and continue to try to find any improvements we can. And that's my presentation. Welcome to take questions.
Thanks so much, Glenn. That was very, very informative. Yeah, we have got a few questions. How did you get the program approved and started?
The CoOp program, it was established when I came here, but that was through our leadership. Basically, just went through we went through our leadership at the time, and it was approved. When I started here, we had 2 co-ops, and it has just grown into what it is now. As far as the Lean project, that was a project we submitted to the Lean Collaborative to as a project that we wanted to do, and it was accepted through that process.
Okay, so who manages your interns on a day-to-day basis?
Our technicians do. So we have a person that's responsible for DME that manages our co-ops that work in the DME program. Well, our coordinator is basically their supervisor for the technicians. The coordinator is the supervisor, and then they're assigned to various technicians depending on what area they're working in. And our bioengineering and our computer science students are working with our clinical engineer.
Okay, that's great. Going on to the reporting, with the new reporting, do you have a better grasp of parts ordered and materials used to fix issues?
Yes, we actually, so on our, let me go back on my pictures if I can. Oh, it's locked. Okay, never mind. So in the one picture where I showed the workspace, what we did was there's a process in Lean that's called 5S, and that's where you standardize the workspaces or standardize a work area. And we took 2 workbenches and we mimicked exactly they're identical, with the exception of parts that are specific to them. So one workspace we do 2 devices on, and the other workspace we do the other 2. All the common parts like IUI connectors, things like that are common to all the devices, latching devices, those all are in the same spot on both desks. The monitor's in the same spot, the computer laptop hookup is in the same spot. All the common parts are in the same spot, and they're in color-coded bins. And then any part that is unique to other devices, they're just in color-coded bins. So if the part is for a PCU only, it will be in a red bin. And if the part is for an LVP, because those 2 are on the same bench, it will be in a blue bin. And the same thing on the other bench, it'll just be for the syringe pump and the PCA. So by doing that, let me finish. By doing that, we were able to determine what parts we needed, what parts we used a lot of, what parts we didn't, and we adjusted our parts quantities, and we actually eliminated some parts from even stocking, and we added parts that we needed to stock.
Okay, that's great. Are there other innovative programs or strategies you are working on to plan for the future?
So yes, there's always things working, but our goal is to have this Lean process throughout our, especially our DME, because those are our high volume items. So that's our next Lean push, is to try to expand this out into our other DME equipment.
Okay, I've got a few questions about certifications here. Do you currently have IT-related certifications or other related education criteria within the various CE roles? If not, what are your thoughts?
We currently do not, but it is definitely something that we have discussed. The management team, the leads, clinical engineer, and myself, we meet regularly, and that's definitely something we have discussed. The advantages to having some type of a IT certification. We have a brother department, sister department, whatever you want. We fall under IT in general, but we have a clinical integration is a partner department of ours that we work closely with on things like the nurse call. We do hardware for the nurse call. They do the software side of it. The monitoring system, they do some of the hardware, or I'm sorry, some of the software components to the Epic interface and things like that, and we do hardware. So we do. It has been discussed, and I definitely think it would be an advantageous, but we do not currently have IT-related certifications as a requirement.
Okay, so I've got another certification question here. You mentioned that certification is a requirement for advancement. Would that be a local requirement, state, or national requirement for CE staff to have certification?
It is just a Cincinnati Children's Hospital requirement. All of our CE technicians are hired, and they don't have to have a certification, but in order to be advanced to a senior technician, it's a requirement to have a certification or a bachelor's of science degree in a related field, EET type thing. So.
Okay, just going back to an intern question. Does the value of the interns make up for time your tech spend training them every semester?
Yes, in a nutshell, yes, because we have them returning. We found, I know that's been a concern. It was a concern of mine when a long time ago when I started here, was that there was some kind of a efficiency loss there, but we have really found it to be invaluable with a high flow of items that come through our department. We do, like I showed you, we do almost $20,000 corrective maintenance, or 20,000 corrective maintenance work orders, and they are an integral part of that. But sometimes it's assisting, sometimes it's they're doing the work. We just check and validate the work. So we have worked it into a efficient process.
Okie dokie, and we've got one here. Says, the process you described represents key fundamentals of improvement, change, and problem solving. Part of this process is to sustain results. How often are your strategies reviewed and even perhaps fine-tuned for even greater improvement?
So we have looked at we evaluate quarterly as to where our processes are, and we look at the various projects and activities that have worked themselves into our department, and so there are things that we are taking care of now that we didn't take care of in 2017, and so they take away from our available resources. So we take that into consideration, but we reevaluate on a quarterly basis. But we ask our teams to look at our processes regularly. One of the things that we've looked at or talked about is having people from groups outside of the HTM shop look at some of the processes. So let's say we take our imaging team and just have them look at some of the things that the HTM group are doing and see if they can see anything in their process that might work better. So we do cross-pollinate, if you will, with things like that. We're always looking for ideas, and we try, like I said early, we try to vet out every one of them, and we take each one of them serious.
Okay, we've got time for one more question. Do you use any type of integration with TMS for parts ordering?
So we do not. As a PartSource Pro member, we do have the ability to be on a work order and request a quote and get into the PartSource catalog. However, we have PeopleSoft as our financial software, and it is not the most friendly to interface to. So our process, we have to actually go out of TMS into PeopleSoft to place orders. All of our order processing is inside of PeopleSoft. However, we have a way it takes us into the PartSource catalog where we do our shopping and do our ordering, and then it brings us back into the PeopleSoft software, creates a request, and then it's generated that way. So it's semi-interfaced, I guess.
Okay, that's great. Thank you so much for taking the time to answer these questions. Thank you again, Glenn, for a really great and informative webinar, and thank you again to today's sponsors, PartSource. One lucky attendee will win an Amazon gift card for completing the post-webinar survey, which will appear on your screen shortly. You must complete the survey to obtain your certificate of attendance. For more information about our upcoming webinars, please visit our website, webinarwednesday.live. And once again, thank you, Glenn, and thank you for everybody joining us today. Enjoy the rest of your day and hope to see you next time.
Thank you.